I'm Jim Sprague. I'm the chairman of the de Beaumont Foundation, and it's my pleasure to welcome you here to this official launch of the Practical Playbook. This has been done by the de Beaumont Foundation in association with CDC, represented this morning by Denise Koo, and the Duke Department of Family and Community Medicine, represented by Dr. Lloyd Michener. We're here to launch the Practical Playbook initiative. This is a project which we hope is going to facilitate bringing clinical medicine and public health back together from this long separation that they've endured. And the separation is long-standing, it's well-known, but not much has happened about it. I started in this business in the early 70s when I went to CDC as an EIS officer. I was aware of it then. I went into clinical practice where I was off for 30 years. I was aware of it then, and I'm very much aware of it now. The Practical Playbook is a tool which we hope is going to do something to mobilize the strengths of the two sides that will be beneficial in doing something about the healthcare crisis that we're currently enduring, and we hopefully that it'll be different than what's currently on offer. It will mobilize the strength of the public health community in the clinical world, in the clinical world, I might say, has almost no idea what the public health world does. And I think you're all aware of that. Now, what we're launching today is version 1.0, and I'm not saying that with any apology. There's been a lot of work going forward with this. It's had a lot of tweaks. It's had a lot of rewriting by a lot of different people, and there will be more to do. We started this almost exactly 2 years ago, and so the amount of work that has been done in that short time period, I think, is truly impressive. And the work was done at Duke, at CDC, by us, and also by the unheralded members, unpaid also members, of the National Advisory Committee, many of whom are here. These people dutifully read, worked on drafts that were put up, made corrections, changed things completely, and the product has come back together again in much more sound fashion than it was when we first started. It's going to continue to evolve. It's not a book, as you know. There will be a book eventually, but right now there's not a book. And it's a dynamic, changing online resource. It can be modified. They can modify it instantaneously. We can put in all sorts of things. So if you see stuff in this as you get through it, going through it, you're now all have been given the release information, so you can now, it's now no longer embargoed. You see things that you like in there, you should tell us quickly, loudly. If you see things in there where there are glitches, as we call them, you should tell us about those too, quickly. Maybe not loudly, but quickly. And if you see things in there that you think we completely forgot, you should certainly tell us about those. Now, there are some that we know about. And I was toying with giving you that list so that you wouldn't send it back, but then I thought, no, that would sort of spoil your fun, so we won't do that. But there are things that we're aware that are not there, and sitemap being the principal one that we're currently working on. But there are a number of other things that we're going to pursue as time goes on. Now, this thing was inspired in large part by this handy-dandy book. The IOM's 2012 release of Primary Care and Public Health, Exploring Integration to Improve Public Health. Now, there are people here from the IOM. They will probably admit that some of their publications have not just run off the shelf, but this one I think did. This has been very popular, and many of these copies are a lot more dog-eared than this one. But this was our inspiration, and I think that the playbook as we offered today is a tool in this direction, and hopefully it's going to be a useful tool. Now, having got to that point, the role of the IOM was really seminal in starting this. And so we were delighted to have participation in this launch from the IOM. And you'll notice in your notes that initially it says that Dr. Harvey Feinberg was going to be doing this, but he stuck somewhere right by air transport problems. People that are here, some of these people that are here had terrible problems with air transport, like 5 reservations to get here. And so we're delighted to welcome Michael McGinnis from the IOM. And he has an extensive CV, which I'm not going to go through. But I would like to comment on a couple of things that struck me. One is that he has a clinical background and a public health background. So he has a foot in both camps. He's seen both sides. He also has an extensive policy background, as noted by the fact that he kept a job through the Carter presidency, the Reagan presidency, Bush 1, and Clinton. Remarkable achievement. Another achievement that is, if people don't understand the significance of the words, but he's an elected member of the Institute of Medicine. He works there, but he's actually, on his own merits, was chosen to be an outstanding contributor and made a member of the IOM. He liked it so much, or they liked him so much, that they brought him back. And he is a senior official now at the IOM. It's a great pleasure to welcome Dr. McGinnis to this podium.
Thank you very much, Dr. Sprague. This is one of those rare events when the weather problems that we've been having across the country have worked in my favor, because Harvey is stuck out of the city, and it gives me this opportunity to participate in a session that is very near and dear to my heart. And I want to give a shout out first to Rose Martinez, who is the board director of the board that has produced this important report, and she and her excellent staff supporting a superb committee, I think have developed a landmark contribution. So I'm honored and grateful to be standing here alongside you and with the members of the panel who you'll hear from later on behalf of the Institute of Medicine and the National Academies. I will be brief, and my messages are 3. The first message is that the 2012 report, sponsored by the Federal Centers for Disease Control and Health Resources and Services Administration, and developed by the Institute of Medicine, was not merely a statement of the facts, and not merely a description of the possible. It was a mandate. And this playbook is therefore not optional. Imagine that you were building a house, not a big mansion, but a simple, reliable, nurturing place to live your life. What if the plumbers and the electricians and the carpenters arrived at the scene and there was no foundation? Or what if the masons and the framers constructed the foundation and the superstructure, but the plumbers and the electricians and the carpenters were far away at another site, no idea, and never even showed? Well, the result would be chaotic inefficiency, ineffectiveness, and often damage to the end product. Yet this is what we have with these sort of parallel, often disconnected enterprises, at least one of which is woefully unsupported in this nation, and that's the foundational element. And that's why we have in the nation today 30% of our $2.9 trillion expenditures in the health sector that's wasted. So it's not optional. This is absolutely essential for the nation as a whole. The second message is that the time is right. The knowledge is in hand. We know that chronic diseases, which are our most prevalent health challenges in the nation, cannot be controlled without moving from inside the clinician's door to outside into the community. We now know that there are essentially 5 determinants of the health of the population: medical care, genetic predispositions, social circumstances, physical environments, and the behaviors we choose, and that medical care is among the least impactful of those determinants across the board. The time is right because the technology is rapidly coming online, both literally and figuratively. We have the digital infrastructure developing to be able to integrate what goes on within our clinic doors and in our public health community to help shape our strategies. The time is right because the policies are aligning. In many ways, the 2,000+ pages of the Affordable Care Act represent the most important public health piece of legislation in our history, because embedded in those words are the principles and the tools to drive payment for health care, which is driven by population health outcomes. The question is how we best develop the means and the blueprint for linking those two, and that's what this playbook is about. And that brings me to my third message and final message, and that is what's needed is the leadership, partnerships, and tools necessary to forge those links. Leadership of the sort we see here at the de Beaumont Foundation, which is, I think it's fair to say, the only foundation which is predominantly committed to ensuring that our public health infrastructure is a stable, reliable foundation on which we can build the nation's health. And it certainly has taken an important step by supporting the development of this playbook. We also are well served by what we see here, who we see here, with Dr. Michener, Dr. Koo, Dr. Montero, Dr. Wood, Dr. Jacob, and the tools that they'll describe and the foundation that they'll help us to envision as we move to the linkage of primary care and public health. We in the IOM are very proud to be part of the activity. The contribution that was put in place by Rose and Alina and her colleagues, their colleagues on the staff of the IOM, couldn't feel better and more grateful about the initiative that's been taken here today. Both the current president of the IOM, Harvey Feinberg, and the incoming president of the IOM, Victor Zhao, a colleague of Dr. Michener's at Duke, are fundamentally committed to this initiative, and we look forward to partnering with you in it. Thank you very much.
Thank you very much.
Thank you very much. Thank you.
Thank you very much. So now I'd like to introduce a key player in the Playbook activity, Brian Castrucci, who is the Chief Program and Strategy Officer for the Beaumont Foundation. Now, I just realized looking at my notes that I neglected to say anything about the foundation. And Dr. McGinnis reminded me is that we do fund only things in public health, and we are particularly interested in projects that have real applicability and that are stressed being boots on the ground is sort of our little buzzword. And I also have something that I need to read to you, which is to say that you can join this discussion online by following hashtag Practical Playbook or at Prac Playbook, P-A-C-P-R-A-C Playbook. Ryan.
Good morning. I am just thrilled to be here today to talk to you about the Practical Playbook initiative. As Dr. McGinnis talked about, as we heard from Dr. Frieden in 2004, we know there's been an epidemiologic shift in disease. Acute diseases like measles and polio, we're not as concerned about those anymore. But now we're concerned about heart disease and hypertension and diabetes. We have seen a transition from diseases with predominantly biological, physiological, and microbial origins to diseases with social and environmental origins. As a result, clinicians can spend hours in treatment and test different pharmacological combinations and really yield very little in improved patient outcomes. We need a change in our approach to health and healthcare in the US. There is no treatment, there is no pill, there is no vaccine that can address the lack of fresh fruits and vegetables in a community, the lack of physical activity options, or the environmental toxins to which we are exposed. The optimal care and management of chronic disease is when we bring together the individual primary care doc, supported by community-level programs from public health practitioners. Let me share a hypothetical example, which we know is real. You think about a community right now, somewhere in the US, and there are 4 pediatric providers, each on different electronic medical record systems, each seeing 4 children with uncontrolled pediatric asthma. Right now, we cannot see that 16-person cluster. There is no one aggregating those data to find that cluster. But what if there was? What if there was someone there to look at those data and find that cluster and do epidemiologic investigation and find that those 16 kids all ride the same school bus? And when they look at that school bus, they find there's a crack in the tailpipe. And we fix that crack in the tailpipe. Probably costs a couple bucks. But what we've saved are the days of lost work for the parents, lost school for the children, and thousands in healthcare costs. But we can't do that today. We can go to the moon, but we can't find a 16-person cluster. And this is the most important of our resources, our health. From the Foundation's perspective, reorienting our healthcare system to adequately respond to chronic disease is the most important and pressing priority for improving population health and reducing medical costs. So with this in mind, we designed the Practical Playbook to do 3 things. First, we wanted to provide the conceptual background so that we all could understand that we really can achieve improvements in population health and reductions in healthcare costs simply by doing one of the most common things we do, something we do every day: partner with each other, talk to each other, and work together. We wanted to outline the necessary steps to establish collaborative health so that we all can understand how to plan, execute, evaluate, and sustain successful projects. And lastly, we wanted to present examples, success stories, along with a direct link to those who did that work. And in this way, we would see how other communities tackled population health challenges, and people can seek direct advice from experienced collaborators who have taken on these challenges and been successful. The Practical Playbook is a companion for leaders throughout the US who share our goal of aligning clinical medicine and public health as partners to improve population health and reduce healthcare costs. Thank you.
Thank you very much, Brian. We're going to continue now with a panel discussion, and so I'd like the panelists to come forward. And I'm going to ask Brian to jump back up here again and to moderate this discussion. And so, and you will introduce your panel. Good.
So now to our panel, starting to my left and going down the row, we start with Dr. Lloyd Michener. Dr. Michener is the chair of Duke Community and Family Medicine. He's the director of the Duke Center for Community Research and a clinical professor at the Duke School of Nursing. Dr. Michener was a member of the IOM committee that led to the publication of Primary Care and Public Health, Exploring Integration to Improve Population Health. Dr. Michener, as with myself and Dr. Sprague and Dr. Koo, are all members of the Practical Playbook Steering Committee. Dr. Denise Koo is a senior advisor for health systems at the Office of Public Health Scientific Services at the Centers for Disease Control and Prevention. She was previously the director of the Division of Public Health Surveillance and Informatics at CDC. Dr. Jose Montero is the Public Health Services Director of the New Hampshire Department of Health and Human Services. He is formerly the president of the Association of State and Territorial Health Officials, ASTO, where his presidential challenge focused on integrating primary care and public health. He was also a member of the IOM Roundtable on Population Health. Dr. Julie Wood joins us today as the Vice President for the Health of the Public and Interprofessional Activities at the American Academy of Family Physicians. She has oversight for public health, scientific, research, and other activities in the AAFP, as well as AAFP's relationships with other medical organizations both here and internationally. And finally, Claude Jacob is the Chief Public Health Officer for the City of Cambridge and a board member at the National Association of County and City Health Officials, also known as NACCHO. Claude is responsible for managing all aspects of Cambridge public health, including public health planning, emergency preparedness, environmental health, school health, community health, and epidemiology services. Dr. Michener, we will start with you.
And can you hear me?
Yes.
Okay. So what I'd like to do is share a personal story about the playbook, how it came into existence, and what my thinking was and involvement with it. I'm a family physician, trained a bit in public health and primary care, and I've been in the city of Durham for more than 30 years, taking care of folks, doing home visits, 3 generations of them actually. And I've been really interested in social justice and how do you help people stay healthy. We've been working in our offices to try and redesign care within the office to make them serve people better. And the medical home model that many of you know about has its roots, one of its roots with the work we've been able to do. We find that it's really been effective. We can make a difference with the people we see in the office, but what's striking is that we didn't do a very good job with the people we didn't see. Makes sense. So as we were working on Medicaid in North Carolina, we realized it was time to get outside the office and actually start partnering with folks in the communities where they spend most of their time and finding ways in which we can more effectively partner with them. Our health department was an absolutely key part in that. And we actually started doing programs together that actually took the work we did in the office and linked it with the work that was being done in the community. And the results stunned us. So we've been looking at small effects of improvements in diabetes and hypertension in the office. But when we started working with our community partners, our health department, our schools, we were able to see in 1 year 60–70% reduction in admission rates for kids with asthma. By the way, the statewide, as we move that statewide, is now 65% reduction statewide for Medicaid kids with asthma. But it wasn't just kids, it was adults, seniors in Durham who are living in our high-rise projects. Couldn't get us to us in the primary care offices because it was hard to do, but when we brought care and partnered forms to them, they got better. We could see it fairly quickly with drops in visits to emergency rooms, things we care about, admission rates, their blood pressure, their hypertension, their diabetes all got better. But even more strikingly, they felt better. They were more active, their lives were better, not because of the things we're doing in our office, so that mattered, but because together we're making a difference and bringing care to them in a partnered fashion that let them stay healthier. So the playbook really came about because of the work of the IOM committee that you heard about, where we discovered there were lots of these stories. They were here and there, and we largely didn't know about them. Folks were reinventing these models, coming to the same discovery all over, and yet we were rediscovering them independently. So the IOM committee pointed out the opportunity and need to come together and outline some methods of it. And the playbook, with the help of de Beaumont CDC, our partners, really point out ASTO in particular, really helped us identify those stories all over the country and bring them together and give guidance. So the playbook is really intended to take what was a 30-year journey in Durham and condense it into something that you can use practically and quickly, because this is a time for change, and what we need to do is make that change easier for all of our practices, all of our public health partners in doing this together. And that's what it's designed to do. And I'm ready. Denise.
Okay. Can people hear me? Okay, great. Well, I'm really excited to be here, and I guess since Lloyd started with a quick story, I will start with 2 lines, one of which is that I often tell people that epidemiology and public health is what saved me from quitting medical school, because I found the medical education to be very frustrating, that we were being trained to treat body parts or illnesses and not whole people and not the root causes of their problems. So I'm really excited about this idea that we can bring our worlds back together. Because as was mentioned by Dr. McGinnis, we all know that health outcomes in the US lag behind many other countries in the world, despite spending more than twice as much as any other country on health care. And we need to improve the health outcomes in this country, and partnerships between public health and healthcare are a critical foundation for improving the health of the American public. We can work together to achieve IHI's triple aim: better care, lower costs, improved population health. Together, we can lower the number of people who need care and improve the quality of clinical care and other services that they receive. So CDC, with HRSA, commissioned the IOM report on primary care and public health, exploring integration to improve population health, to make recommendations on how public health and primary care can work together most effectively. Public health care is a very high priority for CDC. Dr. Frieden talks about it as a key opportunity for the next decade. The IOM report's description of principles for integration and showcasing of success stories are extremely useful. We felt it was important, as you've heard, to take the next steps and develop a set of products to further help partners work together. We thank Duke University and the de Beaumont Foundation for this incredible partnership in developing the Practical Playbook. Guidance on how public health agencies in healthcare, especially primary care, can work together to improve population health. Public health's responsibility is to assure the health of the public. There are tremendous opportunities in the current context to do this even better by working with the healthcare system. The audience here knows this space well: IRS community benefit requirements, innovation grants to the states, primary care extension programs, technologic changes. There is incredible interest in the healthcare system in population health, not always with involving public health, perhaps because we have different definitions for what we call population health. So the playbook is a version 1.0, a central one-stop shop to bring together many, many resources, guidances, success stories to capture, to inspire, and assist our public health and healthcare partners to work together. We need to capture this interest really rapidly before our healthcare partners try to go ahead without us. This is, of course, speaking from public health perspective. This is better, I think, more efficient for the overall system. So we want to showcase even more success stories that are applicable to different health conditions, different jurisdictions, different resource levels, different populations. This world is evolving incredibly rapidly. The playbook can serve as an important vehicle for us to collect more resources and stories, to provide more technical guidance as it is developed, because it is an evolving world, and to learn more about what is working and what is not out there, so that we can spread the word to help others improve care and improve and achieve better health outcomes. Some folks representing some of the success stories are here in the room: Healthy San Francisco, the New Mexico Health Extension rural offices, and Million Hearts, Maryland. So we want them to be able to also tell you more specifically what they did and how they're improving health and lowering costs. It's the power of the story, right? So they are here to give you some more details. The Practical Playbook is a key cornerstone for public health and healthcare integration, for our movement from separate public health and healthcare systems to a health system to help us achieve our mutual goal of improving health in the United States. Thank you. I didn't mean to do it that way. I'm turning it over to Jose.
Good morning. I am really happy, pleased, and honored to be here. And I will explain each one of those different feelings because each one responds to different statements that I'm going to try to make in my remarks. I am really happy to see this finally coming out. It was longer than a regular delivery, pregnancy, and I was telling Lloyd, I feel that I am one of the fathers of this baby. And let me tell you why, because that is what I am honored from being here. My own personal life career and approach has been always looking at how can we do more with less. I come from Colombia, where we are not rich in resources, but we try to integrate many of the community activities with the clinical care to try to get the population to be healthier. We always assume that those concepts are well developed, understood, and accepted everywhere. So when I moved to this country, I was incredibly surprised to realize that was not true. So we still see the same patient again and again and again because we can write a prescription that the patient cannot afford. We can write a prescription that we cannot follow through. We cannot assess why that patient requires a different type of system of care because we don't understand where the patient comes from, what the social conditions or the family conditions of those patients are. When we see the huge increase in diabetes, when we see the huge increase in obesity as key chronic conditions, we realize that the whole population is suffering. But if we look more carefully, we can clearly find out that there are specific groups that are suffering more. And we have no clear way sometimes to detect who those are or to develop more targeted activities and interventions that are going to improve the health of those who need it the most. And that is where we start talking about health equity and where we're talking about the general improvement of the system. And that is what makes me incredibly proud of being part of this initiative. I was lucky that I was the president of the Association of State and Territorial Health Officials. And for 2 years, the way that it works, I had 2 years of a bully pulpit where I was talking about this topic. The IOM report that was showed earlier came out, and we said, we are not going to let this sit. It's too important. It's too important. We at ASTO partnered with IOM, got funding from Private Insurance, United, actually, and started a huge collaborative that right now has more than 80 separate organizations, including CDC, including the American Academy of Family Physicians. It has NACHO as a key, NACHO, I saw Bobby Pastranek, NACHO as a key partner of what we are doing, where we broke down the work to make that book real in 6 different work groups, and we are advancing toward that. I had the opportunity to ask my colleagues around the nation, look, we are all doing something about integration. Let's identify what we are doing right. Stop just looking at what we aren't doing. Let's look at what we are doing right. And we identify a lot of stories, those are posted, and we partner with Lloyd, the Duke group, said, here, we have these stories. We don't have the capacity to do all the analysis and identify what works. You guys are the scientists, you guys are the academics. CDC was awfully interested. No, awfully is not the right word, sorry. Incredibly interested and supportive. So we provide the stories behind this success. So what are those stories? Well, those stories tell us what public health does. We still have outbreaks of measles. We still have outbreaks of pertussis. Even though we have made a huge transition, epidemiologically speaking. A couple of years ago, we had an outbreak of pertussis in California that killed Hispanics, mostly because they were not immunized. How can we identify that if I only look at the 5 patients in my practice? If I cannot look beyond the panel of patients of my practice and look at the population in my area, in my district, in my city, in my county, in my state? So if we from the clinical practice cannot connect to those things and look who is being immunized, why some people is not being immunized, how can we add to that? We're going to miss a lot of things. So we start identifying those things that we have in several places that work. I am incredibly proud of my immunizations program. We have one of the highest rates in the US in New Hampshire. And we work with each single practice. I send my staff to visit, develop a microsystems quality improvement approach, and those lessons are reflected in this playbook. But then we have new things going on in chronic diseases that sometimes we do not understand. The issues around behaviors, the issue and the connection between mental health and some of the chronic conditions, the increased rate of cardiovascular complications in populations with mental illness, the increased rate of complications in populations who are drug addicts, drug abusers, and the chronic conditions that are reflected on those cannot be addressed at a single practice or office visit. When we look at the future, we need to be able to integrate. But then we cannot look at the future as what we do today. And that's the beauty of the playbook. It took the lessons, put them all together in what we work for us today. And then together, from the public health and the clinical side, we can develop the system of the future. So this is not about maintaining the status quo. This is about how we are going to move into an accountable care system, how we are going to improve the medical homes for those patients, how we are going to move maybe from accountable care organizations to accountable health organizations or accountable health communities, where the community participates. And that is the visionary part of this playbook. And I am quite happy to have been part of this process. Lloyd, thank you very much. Dr. Sprague, where is he? Thank you very much to the Doublemount Foundation and your leadership, because several of us may have had ideas, but you made it possible. Your support, you put in your money where your thinking was, is what made this event today possible. And we are going to use this playbook to advance this integration of public health and healthcare and create the system of health that we should have. Thank you.
Good morning. I am so pleased to be here representing over 110,000 family physicians and the primary care workforce here in the United States. The group I represent is thrilled about the Practical Playbook, and we also want to thank the de Beaumont Foundation and the CDC and Duke for helping us get this off the ground. As mentioned earlier, the Practical Playbook is a one-stop shop for tools, resources, and case studies in an easily accessible forum. And the fact that we should be doing this is not a new concept. There have been several calls to action in the past, and as I heard the snicker. But this playbook answers the calls that have been placed in the past at a fundamental and foundational level, something we can actually use and hit the ground running this time. And we're really excited about that at the American Academy. And any individual or group interested in improving community care can pick up the playbook or look it up online, I guess I should say at this point, and begin coordinating with their public health colleagues and primary care colleagues and work on it. It's wonderful to have such a practical resource, hence the name. And that's what this is all about, improving the care of our patients and communities. By working in tandem with our healthcare neighbors, we can change how healthcare is provided and hasten the speed at which integrated healthcare projects are embraced on a national scale. Using the strategies outlined in the Practical Playbook will better leverage the critical public health infrastructure, an infrastructure that has evolved over 200 years, really, in sophisticated frontline service, protecting those of us who live in the U.S. Couple that with the patient-centered medical home, which I think all of us have talked about this morning, which we're proud of and is evolving, and I think this will only help that more. And we have a team of healthcare professionals providing preventive and sick care in the context of family and community, and we have an unstoppable healthcare force here. There are many factors coming together to make this a reality, a desire and a need to provide healthcare to a population. We have emerging healthcare payment models and tools such as the Playbook now that help us improve care together. In this climate of extreme change in the healthcare sector, affecting everyone from healthcare providers to administrators and beyond, new payment models are requiring primary care providers to demonstrate improved population health outcomes. Once short-term measures are taken to optimize treatment, primary care providers need the support of public health officials in structured, targeted, and ultimately integrative health projects to have a meaningful impact throughout the community in the United States. Moreover, with ever-building time pressures and a growing emphasis on holistic wellness, doctors will be more effective if we leverage the competence of public health partners who can expand on their work beyond the walls of our clinics. Family physicians train in community medicine now, and many work in public health, but we don't necessarily know that or call it that. It's a lack of terminology sometimes, or a lack of recognition, and I think we're becoming increasingly aware of that, and I'm really excited about the playbook because one of the things in there, and we may talk about this more in the panel, is we've worked to work on terminology and break down some of those barriers, and I think that's really important. Tools like the playbook will allow this to happen and that interface to happen more seamlessly and to facilitate what we're trying to do as family physicians and what we wish to do and want to do. And I'm really looking forward to having that partnership grow. The playbook adds to the family physician's toolbox for achieving population health. As we've developed the medical home concept along with our primary care colleagues, we have come to understand the importance of team-based and population health. The importance of public health and primary care coming together to improve our nation's health and our healthcare system is well demonstrated by the playbook. And I wanted to share a couple of examples that I think are important that are highlighted in the playbook, and they're abbreviated. You can read about them more if you want to take a look. Hint, hint. One of my colleagues that's on our Health at the Commission in the AFP, Pat Zapp, is a family physician in Maryland, and they applied for a Maryland Community Health Resource Commission grant, and they created a health enterprise zone in Maryland. And what they found was they had a housing complex that had a lot of difficulty with access to care, and they actually created a patient-centered medical home clinic in the housing complex. And they got this grant. Now it's now through the Housing Authority, the Anne Arundel Medical Center, and they opened the practice now in October of 2013. And they have already started to see a reduction in early results, obviously, since it opened in October, but they're working on impacting perinatal mortality, birth weight, low birth weight, emergency room use, hospital admission and readmission, and 911 calls. So that's what they're measuring outcomes in just by placing the clinic within the housing district, and that's through a health enterprise zone in Maryland, and also integrating public health services within that clinic right there on site. So I think that's a really exciting example. Another one is the state health department in Georgia actually has an embedded state health department staff member in our Georgia Academy of Family Physicians office, which we're really excited about. They've been doing that for a number of years. They did that based on some geospatial data that they got through some mapping, looking at social determinants of health and what was needed, and found that working that through particularly some pediatric healthcare needs and some disparities, they've been working specific needs, and I have them listed here that I think are important. One of their current projects involves collaborating to launch a transition care plan for children with special health care needs that are aging into adult medical care. And they have a second initiative they're working on with this particular public health consultant at the Georgia Academy level, sending a public health consultant to primary care practices throughout the state, looking at early identification of hearing and vision problems, particularly related to screening and for reading purposes and auditory and speaking. So those are a couple of examples of integration within the family medicine community I think that are exciting. So check them out on the playbook. And finally, I think there's the question of data that I think is exciting, where we can work together and talk about more. We have an enormous amount of data that we're capable of working on, and I think it was alluded to earlier that that's not interfaced and not talking right now, and it's a huge potential to help our population and achieve the triple aim that we have wonderful opportunity. The average doctor also doesn't have the time or ability to utilize that data properly, and coming together, I think we can make that data available, hopefully, particularly the data from the community, to help us take better care of our patients. I think the playbook addresses that gap well, and we can help teach collaborators at that public care and primary care interface, public health and primary care, to really do better on population health and intervention. So I look forward to ongoing work. I think we have a lot of work to do, but this is an initial wonderful first step, and I'm very excited about it. We are at the AFP as well. Thank you for the opportunity.
Good morning. I will try that again in a different way. Bonjour. There we go. Okay. Good. I'm Claude Jacob, and it is, again, a pleasure and honor to be here on this panel. But I should just be very clear. I'm the non-doc on the panel of docs, but I'm the son of a retired physician, so I guess I qualify in that sense. Representing the National Association of County and City Health Officials, nacho, not nacho. But really, to all the comments, I'm just going to share a couple of remarks just to connect a few dots. And really, for us, it's an exciting day thinking about the opportunities to engage local health departments and our other partners. So with that, I'll talk about public health as a convener, our role as a catalyst of sorts. But at the end of the day, this is an opportunity for local health departments to use the playbook and serve as a compass of sorts. So, and we'll talk more about how that all happens, and this is a great first start. To back it up, and I see some friendlies in the crowd, I acknowledge not only Bobby Pestronk from NACCHO, but I also see a colleague from the Commonwealth of Massachusetts, John Auerbach, Professor Auerbach, former health commissioner. I also see Margie Baudry from the Public Health Foundation. And at the end of the day, I am a proud card-carrying member of the APHA, the American Public Health Association. Just want to put a shout-out out there to Dr. Benjamin. So, NACCHO, we represent over 2,800 local health departments from coast to coast. We are the boots on the ground when you think of local health. When you think about the 3 Ps about how we prevent the spread of disease or prevent injury, look at promoting healthier lifestyles, and at the end of the day, especially in the last dozen years, having this linkage with public safety and protecting the community at large, not just around emergency preparedness, but the day-to-day surveillance work that we do with our health inspectors, for example. So with that, we anchor ourselves on what is the operational definition tied to our 10 essential public health services. Again, these core functions, that framework helps us to anchor our work around gathering data, around having these linkages, which is what we're talking about here, but it's also about framing policies that work, that move the needle. And again, a lot of this has been work from the CDC and other partners over the last couple decades. The terminology may change, but just know that the framework is still the same. It's really about making sure that we look at the information, the data, that we link the services and the resources that we have, but it's also about moving the needle around the policies, the systems, and the environmental changes. So this is an opportunity to represent local health departments as collaborators and not competitors. We recognize that there's an imbalance in the way that the resources are allocated around the delivery systems and the work that's done further upstream. So this is an opportunity to look at the playbook, hear the stories, try to make sense for what works within our respective municipalities. We at the Cambridge Public Health Department, and I know it was mentioned, so my day job, I serve as a health officer in a city of 100,000 residents. We are a medium-sized local health department by scale. We are the second largest local health department in the Commonwealth of Massachusetts, yet we are in a very densely populated urban environment. So we are in the top 10 most densely populated cities in America. We are 6.5 square miles. That's it. And I know that to my colleagues in the rural pockets of the state or in the nation, they have that entire population over hundreds and thousands of geographic space. So why that's important, this is an opportunity to talk about our linkage to a delivery system, making use of this resource, which is one of many. But at the end of the day, it's about demonstrating how local public health has had to become even more nimble in making use of limited resources. And so the convening power, we're going through a process now where we've brought together partners and stakeholders from around the city having to do with the voluntary accreditation process that's been underway now for a couple years. And so it's an exciting time for us to look at the health needs in Cambridge. The misnomer about Cambridge is that it's only about the Titan universities and the million-dollar homes. We are talking about the other end of the spectrum, which has to do with the fact that 15% of our residents live in some subsidized housing, the fact that half the kids in the public school systems are on the reduced and free lunch program. And so there's the spectrum of the population, big P, that we are required to address. That it's not just about the panels that end up in our safety net delivery system, but it's about the broader needs of the community. Our office, for example, is across the street from a public housing development. And so when the providers ask about, well, what about patients that can come in and participate in our smoking cessation courses? We say, well, true, but our role is to look at exposure to secondhand smoke for all the residents, regardless of where they get their care. And so the playbook share some stories. These are things that you can bring back to your respective communities and talk about the linkages to delivery systems, the role of local health, the involvement of partners like academic institutions, the nonprofit communities, public safety, or the private sector. And so this is an incredible opportunity to not only work with public health as a convener, but also think about how we connect the dots. Again, further upstream, you keep hearing about that metaphor, but why that's important is that it's not just about the patients that end up in the emergency department or in a clinic visit, but it's an opportunity like the work we've been doing with the Men's Health League. It's a health disparities initiative that focused on the needs of diabetic and hypertensive men of color. We recognized 2 decades ago that there was an imbalance with having the guys connected to care. So we came up with this model, again, initially funded by the Office of Minority Health and sustained by the work of the State Department of Health. And what it's allowed us to do is to focus on the needs of the guys that were not linked up to a primary health care provider. And so we've been able to show how we move the needle. It requires a lot of bandwidth to have the connectors, the outreach staff, to have them tied to a navigator. Prior to a few years ago, we didn't have that function at our department, and we had to create it and orient it, and we're still learning how that works. And so it's our convening power, it's our ability to at least connect the right dots, but at the end of the day, this opportunity with the playbook and thinking about our work around accreditation allows us to serve as a compass. And so it is about looking at the priorities, it is about making sure that we have an appropriate allocation of resources wherever that's possible. We're in a city where there's strong support for our public health work, but we recognize that that's not the case in many places. Plus, we're in a very decentralized state in Massachusetts, and so it requires that, at least at the local level, the role of city government to really help shore up the resources that we have available to do the work day to day. And so I'll pause there to say that it is an exciting day. Believe it or not, the new season, spring, will be here in 16 days. And for all it's worth, we are just talking about one opportunity here to learn a little bit more about the version 1.0 of the playbook. It's not a cure-all, but it is an opportunity to recognize how could we do this a little differently. And so I think back to the IOM report, not just from a couple years ago, but back to the report in '88 that talked about the future of public health. And at that time, it talked about the fact that, by and large, the public health workforce is not formally trained in public health. And so for me, it's really an example of how we've been able to enhance the linkages with academic institutions. I can tell you, as a point of fact, for the last 10 years, 15% of the growth of our health department has been directly tied to projects by students. They're free labor. They come in, they help us, we cobble some grants, shift some resources around, but there are whole units that exist today that didn't exist 10 years ago. And so it's just one small illustration of how the IOM findings are then translated at the local level, and this is just one other opportunity. And so, again, I thank you I thank the Beaumont Foundation, CDC, and our friends at Duke University for this opportunity to share, and I'm looking forward to hearing other comments and remarks. Thank you.
Please join me in thanking a distinguished panel who did a fabulous job today. But we're not off the hook yet. So let me ask for the panel members. We have an incredible diversity here in the panel: academic health officials, health policy experts, leaders at state and local government, national government. What would integration do to make your job easier or change how you do business? Lloyd, why don't we start with you?
Actually, some of the examples I gave earlier speak to that. What I'm looking for as a academic family doc is finding ways in which integration reduces the burden of the people that I care for. And so they don't have to come in time after time again, generation after generation, for illnesses that we actually know how to prevent. But I can't do it alone.
Well, from the CDC or the public health perspective, I think integration will make us all more effective because we'll work together. There's limited resources, and we should be working together. It's not efficient for the overall system for us to be duplicating efforts in silos.
I am the same boat. When I look at the health of the population in my state, I want everything to improve and to improve quickly for those who are even in worse circumstances. Through the work of integration that is going on, we have been able to reach out to clinicians who get the population that they are working on, understand what other services are out there, and have been more effective and efficient in using those services. My hope is that now that we can publicly talk about the playbook, they can use it and find this as a neutral source, something that is not the state telling them how to do it, but that they can look at, discover where their strengths are and what things they don't have, that they can look to us to jointly improve. I'm not asking them to buy into everything that I do. I don't think that that will be appropriate. But that joint development of new models is what I hope that the playbook would allow me, building in what we have, because there is a lot going on that has been successful.
Hopefully what we can see is actually demonstrated outcomes measures that we haven't been able to previously document, both when we have the integration together with some of the data changes that we're talking about, where we have the success stories here online that we, with the information like you were talking about, the 16-person cluster and the interfaces that we haven't had. If we can bring these together, we have a lot more power that we haven't had before. And those will both improve efficiencies, but will also improve health, and we can document it. And those are things that we haven't really been able to do before, and I think that'll be really powerful.
Two things. It's one about approach. Each one of you could boil your own water to have access to potable water, or we could have systems in place that take care of this for the entire room. And so, you know, from where we sit, the clearest example that I can think about is the fact that a third of my staff are the school nurses. And they literally sit in and cover the terrain of the public schools in Cambridge. That's an expensive unit. But not all school nurses are a part of the health department in Massachusetts. Most are a part of the school department. So what the integration looks like is the fact that in real time, we have access to providers through the Cambridge Health Alliance. We have access to the records that the school nurses manage in whatever databases that they have access to. But we know that half those students, for example, are patients within the safety net delivery system. And so what it looks like for us is making use of our limited staffing capacity, but tied in to some system that allows us to look at this information. Now, again, there are a number of different firewalls that exist for us and how we access those records, but at the end of the day, it allows us to cover the health needs of the broader community.
Data is incredibly powerful. How we use it and where we obtain it is critical. There is not a tradition of sharing clinical data with the public health sector, and sometimes the population data is too broad, that is not useful for the clinician. If we break those barriers and integrate the management of that data and develop really good measures, that will help us first to know what's going on in reality and develop more appropriate measures to improve it. Again, this allows for that. That's a clear role for health entities, but it's a clear role for health plans. We cannot forget the health insurance companies and their critical role in managing populations and how they need to be connected within the system. It doesn't have to be just private payers or public payers, it's whatever payer. So plans that are self-insured, the private payers or the state, the government through CMS, we all need to be able to look at this data, integrate it, and develop joint goals. And this helps to that clearly.
Thank you. One more question. Right now, we're seeing a lot of good Twitter activity. Remember, hashtag Practical Playbook, @Prac Playbook. And so people are going to the site. It's live now. This is a practical playbook. So what's the one practical thing that someone can do tomorrow, having viewed the playbook, to help this movement move forward? Lloyd, do you want to start with that?
Actually, one very immediate one I would suggest for anybody who's watching is get in there and find out something that's going on in your community or one in a community like yours that you'd like to learn from, partner with, and do in your home community? Do something.
Yeah, we go with the just do it theme. The most obvious one, of course, is reach out, connect with the other side. If you're public health, look around, see who the primary care networks are. We have tools in there to try to help you find them if you're not used to it. And of course, on the healthcare side, although you can Google your health department, but we've also got the links to NACCHO, ASTO. Find out who the health officer is, make an appointment either with them or somebody in the health department, because it's all about relationships.
Look at your role in the system. Either you are a provider or a public health person. Identify what is your key priority, and by looking at the playbook, look at what you are doing right and what you aren't. With those two things, identify who you call. You need to reach out. You cannot do this by yourself, sitting there and saying, we are changing the system, because that doesn't work. Identify one good thing that you can give the others and one thing that you feel is a barrier, either on your end or the other's end, and reach out. So you break that one and spread this one.
We talked a lot about medical home for family physicians. We are realizing we are doing pretty well at building our medical homes. We are still needing to work on building our medical neighborhoods, and we're emphasizing that public health is an important part of that medical neighborhood. So encouraging family physicians to reach out and build in public health to the medical neighborhood. So I agree, it's reaching out and finding out who those people are and how to build that into the medical neighborhood. And it works both ways. And like you said, reaching out, finding the role and building that in, finding one way to do that. And as I mentioned in my comments, a lot of times we're finding with our members that they're already doing some things, but they don't identify that that's what it is. And so breaking down some of those barriers and terminology is a big deal. So I think the playbook has some really good tools in identifying what those are and finding, I agree with Lloyd, one thing to do and building on it and moving forward.
Great question. I guess I'd just say two things, just adding to and agreeing with the comments already shared. Where to start, besides getting to know local health, just know that the caveat is that we come in all sorts of different shapes and sizes. And so recognizing and just getting to know who you have as a resource in your own backyard, that's a place to start. A simple introduction like, hey, I'm your delivery system, I'm a nonprofit community, I'm part, just get to know. The other is that the playbook represents, again, I referenced the 10 essential public health services. So if you sort of drill down to number 3 and number 7, number 3, the third one talks about informing, educating, and empowering communities about health issues. So this is a way to tell the story and at least get the information out there in a way that folks can understand it. Number 7 talks about the linkages to healthcare and health services. And so here we're talking about this integration between primary care and public health. And so at the end of the day, for those of you that are interested in how that framework is sort of operationalized, I would just suggest that that's a place to start. Introducing yourselves, but also revisiting the framework and seeing its application.
Thank you. So now we'd like to turn it over to the audience for questions. Please feel free to ask questions about the playbook itself, the website, the general conversation around integrating primary care and public health. You are free to address the panel members individually or myself, or we'll just kind of sort them out as we go. So first question in the back.
Janet Williams, American Medical Association, and I'm the person at the AMA who, when you say SGR, it means Surgeon General's report. It was very hard when the new folks came in, because I've been at the AMA for 11 years, and I kept saying, they kept saying SGR when I got there, and I said, oh yeah, is there another one coming out? And so I appreciate the opportunity to be the public health person at the AMA, and I really wanted to talk about what the playbook means to the individual doctor, what it could mean. Part of the discussions I've been having, I've been fortunate to be on the ASCO calls with Sharon Moffitt and Dr. Mishner, and I think part of what we're really seeing is that there's a lot of solo practice and individual docs. I mean, even as we're moving to this big global healthcare. And so my real question is, how can we improve the system within those small offices so that this playbook can have some applicability. And I'm also offering, though I might get back to the AMA and not be allowed to do this, but I'd like to partner with the panel and maybe do a series of educational sessions on how to use the playbook. But I really want to talk a little bit about what kind of systems do we think for this individual doc to be able to use the playbook, because they're maybe not the rock stars. We're going to start a clinic in a housing, but they really would benefit from this tool.
Julie, do you think you could respond to that?
The playbook is really designed more to start at a systems level on 1.0. I think that is a great opportunity, and it's something that can provide some excellent resources to start, but I think we have some opportunity to work together and move forward to look at ways we can help and partner together potentially to help provide educational resources for docs at the individual level. Lloyd?
Just very briefly, it's a great question, and in fact, many of the examples we have are networks of providers that aren't owned. They work together. They partner. They share data. It's not a governance model. It's a collaborative model. And those examples I cited, about 65% reduction in admissions, actually came out of a loose affiliation of a network called the Communicare of North Carolina. That was the statewide implementation. So our small practices still have critical roles in this, but it's part of larger systems. It's thinking about systems and acting like systems for our communities.
Here, can we take your offer to do the education? I know that you are part of one of the ASTO groups. Dr. Eunice is here. Yumi. Okay, here. We can connect after and figure out with Lloyd and Yumi and Sharon how to do that. Certainly the foundation and Duke has a training approach. We can amplify that through that, or we can use several other venues like the IOM roundtable in population health, and I think that I saw that you are here. So there are many places where we can use to amplify this playbook and reach those groups.
Hi, I'm Joey Nichols, and so the other side of that issue is that I'm one of the now majority of family physicians who's employed by a large healthcare system, and increasingly primary care is being delivered by these large systems. So my question as sort of an upstreamist, troublemaker type public health trained family doctor, how can we, those of us with my kind of unique mindset, how do we advocate for those large health systems to get on board with this systems transformation, given that they're often the largest employers and wealthiest employers in many of the small communities in the United States, and they have somewhat of a mandate to get involved with population health. It's a role that's increasingly thrust upon them. How do you show up as like the helpful guy in the tights and say, like, hey, I'm here at just the right time?
I'll take a first crack at that. There's lots of expertise on this in the audience as well. It is the right you are the right person in the right place at the right time. The question is how to get listened to. And I think that's where all organizations have their structures, and knowing who is starting to think about it. My guess is your CEO is, your CFO is. They may not know how to. So this is a place where helping them connect in, working if you're in an academic center with the Council of Teaching Hospitals and John Conroy back there, about how do we get this, help this message be heard by members of those groups. And actually I would add very quickly that one of the groups that's been most interested in the playbook, to my delight, has actually been the large systems, because they see this as their future business model and they want to learn it, and they're bound and determined to do so. So they'll go reach out, just like we've been saying, and expect to actually to be very busy.
Claude.
Two comments. Again, not speaking as a doc, but just a couple illustrations of how this has worked for us over the course of a couple decades. So if you imagine that the providers see a lot in their practices and they have that insight, and the way that this works, at least in a broader community, is that you've got to be visible or connected outside of those four walls. And so my suggestion would be taking advantage of any sort of advisories or task forces. I know it requires sort of, energy and time, but it's worth the investment. We have a citywide effort around childhood obesity that has been in place for over 20 years that was co-chaired by a city councilor and the chief of the Department of Pediatrics. The work around the Men of Color Health Initiative, the observant of record was the chief of the Department of Medicine, who then helped create the task force that's still in place 21 years later. And so what I'm saying is that clearly you have your day jobs and seeing patients, but it's also an opportunity with the appropriate partnerships to figure out where to go, where to be at the right tables, to give the right input. And that's where we local health departments can help because we are more familiar with that environment. But the caveat is that, again, we have limited resources. We can't be in all places at all times. It's really about answering what I would call the WIFM question, WIIFM. What's in it for me? And so if you can at least get into those conversations, the last example is that we, through the Men's Health Initiative, were able to invite one of the physicians to serve and do a public service announcement. We wrote the script. We were very protective of their time and basically got them some more face time to have the PSA, which you can go on, the cable TV and see that today. So that's the opportunity. I would just suggest connect, again, further upstream, but think about the broader community networks.
Just
Leverage.
Just
Leverage,
one thing.
engage others to do that job.
Just one thing I would like to add is when you use the analogy of kind of showing up in the tights and the cape, remember that if you're the Superman, your public health department is your Batman. They're not the folks who don't have superpowers. And so kind of meeting them on that level and understanding that together you can form a League of Justice instead of all kind of working separately, it's very important. More questions down here in the front.
League of Justice, I like it.
Liz Weiss with the Association of Schools and Programs of Public Health. Thank you for the invitation to the launch, and we've helped in the beta test, and we're looking forward to the final results. Just to follow up on Mr. Jacobs' point about engaging students to work in the health department and looking at academic institutions and our role, is there a way to query the playbook to identify the academic institutions and the programs that are in place to support these integration efforts?
I don't know if it is yet, but if it isn't, it will be.
Yumi.
Yumi Shatamajaris from Georgetown. I was wondering if you found common themes or characteristics with the success of Orienting.
Oh, absolutely.
The question was, are there common themes? Actually, we did with the IOM report, and we certainly did with the playbook. And actually goes to some of the questions. Every one of those examples started because somebody cared. And they got out of their usual norm, and they reached out, and they started to build. And it always took time. Something we actually haven't talked about here. The playbook actually talks through how to avoid some of those missteps. But like all change, it starts with an individual who thinks there's an opportunity, and then they build out, and they continue. One of the striking points of the playbook is how old some of the examples are. I mean, there are new ones of October, but there's some that go back many, many years. And again, it was because folks came together and then others came in. And the guidance of the playbook is if you don't have that in your community, first check that it isn't already there, because it often is. If it isn't there, how do you get it started? And we have some guidance on that.
We have time for two more questions in the back.
Hi, I'm Mike Stover from Georgetown. Thanks for this great discussion today. I'd like to make a suggestion, see what other people think, that the community health needs assessment requirements under the Affordable Care Act are really a tremendous opportunity. I know there's some things in the playbook I saw on that, but it really works because, from the what's in it from me perspective, the hospitals have to do it, and they're also expected to collaborate with health departments. And health departments need to do the same thing to be accredited, using different terminology. It helps to kind of the activity, one of the activities you talk about, plus also brings people to the table. So I wonder whether you have reactions to that.
This is a great question, Mike, actually. My colleagues at CDC in the Office of the Associate Director for Policy are working with a bunch of partners to develop a technical package of guidance and templates to be released hopefully in the next, they said, I don't think we'll get it to you for launch, but that's the nature of the playbook. It'll be this dynamic collection, and as things are developed, we'll put it right in there. And so when that technical guidance is developed, the intent is to get it out there so that hospitals will be thinking about it before they enter their 2015 IRS cycle. So
we do have a great example of that in New Hampshire. We have a health system that improve high blood pressure management to more than 85% of their patients being under control. CDC actually recognized them a couple of weeks ago. They used the community assessment and then got the money from the community benefits. So it is the right model type of thing. We were lucky we had Lloyd in one of our calls with them a couple of months ago discussing how the playbook actually highlights some of the things that they were already doing. And that's the type of thing that I was referring to, using these for the models of the future. So where do we go from here? Laura Herrera from Maryland is here. They are doing great things with Million Hearts as well, looking at that specific part. So there are examples out there. We just need to bring those to the forefront and make those more visible. There are great things happening. We need to be able to look at those.
Okay. Oh, thank you.
Just a comment. I think this is still on. Okay. Just would add that typically the needs assessment look at what's the burden of disease, say, in a community. But I would also add that the exercise we're going through right now through the accreditation process allows us to look at the assets that also exist in community and the allocation of those resources. So it's in that space that it's a little bit of a crosswalk between the IRS requirement, which is on a 3-year cycle, and the FAB, the Public Health Accreditation Board requirements, which is on a 5-year cycle. And just looking at not just the burden of disease, but also what are the ways that we have shared capacity and the resources and the tweaking of resources so that we can help communities further upstream. So that's, to me, the other opportunity tied to the delivery systems.
The other thing that it makes me think of, Mike, which is a great point, is I had a long conversation last night with Steve Teutsch from LA County, and this is pieces, again, not yet in the playbook, but one of the questions is other resources. It's not even just in health and healthcare, because people are getting it. It's about health in all policies, right? Mm-hmm. And of course, I, being at CDC, think CDC stands for Centers for Disease Control and Prevention, but I've also been learning that CDC stands for Community Development Corporations, right? Yes. And you think that SIBS stands for siblings, but I learned last night that SIBS stands for Social Investment Bonds. And what we need to do is find the examples out there, learn more from them, and translate them and put them in here so that people can figure out other ways to identify resources to support us in improving health.
In the third row.
Hi, Rebecca Etz from VCU, Department of Family Medicine, Population Health. I'm a cultural anthropologist. I'll out myself right now. My research is around practice transformation and clinical and community partnerships. So I probably talked to multiple practices in every state in the country for the last couple of years. Lots of whom are doing the kind of work that you're talking about, the chuckles, right? Mm-hmm. The question that comes up repeatedly, and I'm wondering if there's practical advice in the playbook for it, is the problem of the information exchange that prevents the clusters, identifying clusters like you talked about. And it's a two-part problem, right? It's the lack of systems that actually speak to each other, but it's also an interest in doing interprofessional work, although we're not trained in a language that is interprofessional. So there's a prevention of the sharing of useful information. So you talked about what's useful to the clinician as well as to public health, and that information exchange. I wonder if you can speak to that.
Good question. Sure. So on 2 points you raised, really. One was the information exchange, and there is some piece in the playbook. We have one on EHRs and information exchange that say EHRs have great potential, and it sort of lays out some of the tips of how to get started. Again, it's all about the relationships, how to get started, start small, think about very specific targets. You know, being in public health, we're used to some of our partners saying, I want all the data. You know, it's sort of like it's a research project. No, stick to the data you need for the purpose you need it. And so there's a lot of references and hyperlinks to existing websites. Like, I think somebody's here from the Office of the National Coordinator to say, here are some other examples, beacon communities, you know, third parties who can help support the health information exchange, because it may be that you yourselves can't do it. It's back to this idea of jumping into other larger systems, communities. We have several examples, the success stories, where the data exchange was really key, setting up some way to share data. So that's on one side. The other issue that you raised, critical issue, you and I co-chair the workforce subcommittee of the ASTO support of the Primary Care Public Health Collaborative. Hot topic we are talking about right now is interprofessional education and interprofessional work, because it's, it's not just about education, it's about how do we actually do this work together to improve health, take that larger systems perspective. That's something that we are actually thinking very strongly about. In my former position, just before this one at CDC, I was in charge of workforce, scientific education, professional development. And one of the things that we supported, and several of our partners are in the room, is something that we called academic partnerships to improve health. So not just to serve as a vehicle for getting money to our academic partners, but said strategically, these partnerships with AAMC, AACN, Association for Prevention, Teaching, and Research, ASPPH, who's here in the room, should be with an overarching model of the workforce needed to improve health. And how do you all work together interprofessionally, both in the education side and then the other discussion we've had on our workforce committee in the practice side. So some of the work that we're funding, for example, with AAMC is this systems-based practice, practicing to improve health, so that larger context. One of the fun things that we're probably going to do, and Brian and I were talking about this, is we have at CDC some funding from Pfizer for a fellowship that we've had for a decade now, which is unfortunately ending, but it was a fellowship to create physicians with a population health perspective in 1 year. There's obviously a selection bias if they come to CDC. But one of the things that they've given us, they are no longer willing to fund the fellowships because Pfizer's getting out of that business, but they said, how are you going to transform the legacy? One of the ideas we're thinking about is a Khan Academy style competition, the way they did with, I think, AAMC and AMA, to have them, young folks, produce the videos on how to use the playbook to improve health. And they can be from multiple disciplines, so get them to work together.
So before we close, we conceived of this project almost 2 years to the day, and you cannot do this type of project without visionary leadership at the senior levels at a foundation. So they say if you like what you do, you never work a day in your life. And so I need to thank Dr. James Sprague for his support of this project and his leadership that he's provided throughout. And also, without the faith, trust, and vision of a strong board, we could not have made this happen. We have 4 board members in our front row: Dr. Gregory Wagner, Ms. Carol Masoni, Mr. John Stevens, Mr. John Auerbach. Ms. Masoni was there when we actually conceived this project 2 years ago, and so she gets to see it now come to full closure. And we thank you for letting us do this great work and supporting the activities of our great colleagues. So that kind of wraps up our event today. We will be here for a while. Please feel free to approach any board member or any panel member or Dr. Sprague, myself, with any questions that you may have. You can always reach us through PR Collaboratives and continue to tweet #PracticalPlaybook @PracPlaybook. Thank you all for coming. It's now on you and us to go do something and make this movement happen. So good luck in doing that. Thank you very much.
Sorry, I'm going to